Guys, I'm Sam Philbrick, and I'm here to do a quick and easily digestible review of the optic neuritis treatment trial. What is optic neuritis? Very simply, it's an inflammatory condition that affects the vision. Now, this condition preferentially affects the female gender, preferentially affecting women, and second to only to glaucoma, it is the most common vision condition that affects people younger than the age of 50. Now, optic neuritis, we've just given a very simple definition. We're going to get a little bit more complicated when we talk about categories. So we've got optic neuritis, and optic neuritis can be typical or it can be atypical. Now, with typical optic neuritis, it's typically divided into two types. There's neuromyelitis optica, optic neuritis, or there is MS-related optic neuritis. Atypical usually refers to optic neuritis that's secondary to inflammatory or infectious or autoimmune conditions. Think of things like lupus causing optic neuritis, and you're on the right track. That said, this video is not going to be talking at all about atypical optic neuritis. We're not even going to be talking about neuromyelitis optica related optic neuritis. We're only going to be focused on optic neuritis as it relates to MS. And why is that? Well, it's because the optic neuritis treatment trial was done particularly because of MS. It's known that optic neuritis, sorry about that typo, can be a precursor to MS. But how to predict progression, in other words, how to know who's going to progress to MS, was unknown. How to tell who was going to progress and how many people were going to progress to MS once they had had an episode of optic neuritis was pretty in the dark when this study was started, which was back in 1988. It also wasn't really clear what the best treatment was. So remember, MS is an inflammatory condition, and so when this treatment was started, people said, well, let's take a look at whether or not steroids can be beneficial in treatment. And they actually followed patients from 1988 all the way through 2003. So this was a really great trial for seeing some long-term effects of treatment. Now, the optic neuritis treatment trial investigated three different treatment options. There was oral prednisone, 1 mg per kg a day for 2 weeks, IV methylprednisolone, high dose for 3 days, followed by an oral taper for the remaining 2 weeks, or just placebo for 2 weeks. How do we measure outcomes? Well, 4 different ways. Visual acuity was measured, contrast sensitivity, just like this chart over here, was tested, color vision was tested, just like this, and visual fields. We see a normal visual field chart over here. So how often do we check these 4 outcomes? We checked them 7 times in the first 6 months, and after that yearly for the remainder of the trial. And did we do a general neuro exam for the patients? Absolutely. We did a baseline, did a test at 6 months, and every year after that for the remainder of the trial. So what were the major findings from this trial? First of all, that high dose or that combination drugs hasten but don't otherwise change recovery. So, right, high dose here, high dose drugs speed your recovery, but they don't improve your ultimate outcome for visual fields. In addition, oral steroids, that low dose oral steroid regimen for 2 weeks was associated with increased risk of recurrent optic neuritis, about double the risk. And after the trial, the favored treatment was high-dose steroids and then taper or do nothing. Or I'm sorry, the favored treatment was IV steroids and then taper or don't do anything. And now the favored treatment is high-dose or do nothing at all. The second major finding is that vision recovers regardless of the treatment that was employed. Basically, whether you use placebo, whether you use high-dose steroids, or whether you use regular steroids, the patient's ultimate outcome several months down the line is going to be pretty much exactly the same. Whatever damage is done permanently at the very beginning is done permanently long term. You don't regenerate your myelin, and while people might recover much of their visual function once the inflammation settles down, long-term damage that's done cannot be stopped by starting a patient on high-dose steroids once they become symptomatic. The third major finding of the story of the study was that white matter lesions predict progression to MS. Now, asymptomatic white matter lesions were found to be the strongest predictor of progression to MS. And how strong? Too strong, if you remember the Titans. A great moment in that movie. But maybe this isn't the best time for jokes. After all, if you have an episode of optic neuritis with an MRI that has even one lesion on that MRI, your MS risk is 72% in the next 15 years. Now, you might say, risk? What do you mean your MS risk is 72%? Isn't that already showing separation in time and space? Don't they already have a full-on diagnosis of MS? Well, not quite. This sounds like a great opportunity to review the, drum roll please, 2010 McDonald MRI criteria for MS. That's right. Great. Okay, so what are the actual criteria for diagnosing MS based on an MRI? Well, we need one visible lesion on a T2 scan in at least 2 of 4 locations. So we're already talking about a couple different locations. They need to be either juxtacortical, periventricular, infratentorial, or in the spinal cord. In addition to that, you also need either a new T2 lesion visible on a follow-up MRI after your initial scan, or an MRI showing gadolinium enhancing and non-enhancing asymptomatic lesions. The fourth outcome is that for vision, your outcome is both favorable and stable. In other words, 15 years down the line, more than 70% of patients who had optic neuritis ended up having a visual acuity of 20/20 or better. So even if you have optic neuritis long-term, your vision is still probably going to be good, even if you do have some deficits in color vision, contrast sensitivity, etc. Now, this trial ended in 2003. It's 2015 now, and medicine from 10 years ago, it's ancient history, right? So what are we doing currently? Well, if optic neuritis is functionally limiting for the patient's vision, then it's appropriate to offer high-dose steroids, counsel on the benefits, which is that you'll hasten recovery, the limitations, which is that we can't improve long-term outcomes, and the possible side effects of any steroid medications for patients. Now, we mentioned earlier that it used to be good practice to only say do high-dose steroids for the first 3 days by IV. Now it's accepted to prescribe high-dose steroids initially via PO route as well. So you can go 500 milligrams for 5 days, or you can go 1 gram IV for 3 days. In the long term, if a patient has lesions on the MRI, which we noted earlier was predictive of progression to MS, you might want to consider starting the patient on a disease-modifying drug right away. What's the benefit to that? Well, the benefit is that you may slow the clinical progression to clinically diagnosable MS. In other words, you might slow the disease progression enough that it takes longer before they have their next attack or before they develop new MRI lesions. That said, treating with disease-modifying drugs right away has not been shown yet to decrease the long-term disability of patients with MS. So if the patients don't have lesions, we don't treat. But if they do have lesions, some trials have shown benefit from glatiramer acetate or beta interferon. I should also point out that the favored drug for MS is a PO drug called dimethyl fumarate, and we should be familiar with the trade name because it's used commonly, which is Tecfidera. That said, Tecfidera's risks and benefits were not addressed in the 2014 Lancet review of optic neuritis, which was the most recent reputable journal article I could find looking at recent evidence on the treatment of optic neuritis. So this concludes my overview of the optic neuritis treatment trial and a brief update for current guidelines. Thank you for listening, and I will see you out there on the wards.